So, definition of gestational trophoblastic neoplasm. It is a group of malignant neoplasm that consists of abnormal proliferation of the trophoblastic tissue that may follow hiatus for mole or non-molar pregnancy like abortion, ectopic pregnancy, or full-term pregnancy. And there is 4 different types of gestational trophoblastic neoplasm, which could be either invasive mole, choriocarcinoma, which is the most common and usually associated with a high level of the beta-HCG, or could be placental site trophoblastic tumor or epithelioid trophoblastic tumor, which is usually rare and associated with a low level of the beta-HCG. So 50% of case of gestational trophoblastic neoplasm usually arise after molar pregnancy, but it can be after abortion or tubal pregnancy in around 25%. It could be after term or preterm pregnancy in around 25%. And the most common site of the metastatic disease usually is pulmonary, which is around 80% of the patient, vagina 30% of the patient, CNS usually 10%, but usually all patients with a CNS metastasis usually have concurrent either pulmonary or vaginal metastasis. Hepatic, which is around 10%. Clinical feature, usually patient can be presented with abnormal uterine bleeding, which can be after molar or non-molar pregnancy, amenorrhea, which is more common after non-molar pregnancy, pelvic pain or pressure, and this is mainly because of uterine enlargement or if there is bilateral ovarian complex cyst, beta-HCG stimulation effect like bilateral ovarian thecal lutein cyst, hyperthyroidism, and rarely patient may present with a hyperemesis or preeclampsia. Symptoms of metastasis. So if there is a lung metastasis, patient usually can present with a shortness of breath, cough, chest pain, or hemoptysis. If there is a vaginal metastasis, vaginal bleeding, or purulent vaginal discharge, or if there is a CNS metastasis, will present with the neurological symptoms. Rarely fertilization, and this is mainly because of the thecal cell hyperplasia lead to the elevated the level of the hormonal testosterone, or nephrotic syndrome, but both is very rare. So what about diagnosis? So following molar pregnancy, if you have a weekly beta-HCG level plateau over 3 weeks period, mean day 1, day 7, day 14, and day 21, this can diagnose as a gestational trophoblastic neoplasm. If you have increase in the more than 10% across 3 values over 2 weeks duration, day 1, 7, 14, if there is persistent of detectable beta-HCG for more than 6 months after molar evacuation, if there is a histological diagnosis of choriocarcinoma or invasive mole, and if there is evidence of metastasis. So this is following molar pregnancy. Following non-molar pregnancy, if there is elevated beta-HCG with evidence of metastatic disease, usually you can make a diagnosis, and usually biopsy should not be performed because this tumor usually is a highly vascular tumor, and by doing biopsy there is a high risk of life-threatening hemorrhage. But if you have elevated beta-HCG with uterine enlargement only, and there is no evidence of metastatic disease, you may consider histological diagnosis if you are not convinced, because it may be another pregnancy, it could be retained tissue inside the uterus after the pregnancy, or it could be gestational trophoblastic neoplasm. So diagnostic workup, so baseline laboratory test, usually quantitative beta-HCG, CBCD, hepatic, renal, and thyroid function test because of hyperthyroidism risk. Imaging study, so usually we do pelvic ultrasound. This is to make sure that you are not dealing with another pregnancy. Chest imaging, baseline chest X-ray. And why we use baseline chest X-ray? Because this is the imaging that we need usually for FIGO staging and WHO prognostic score. So we do usually baseline chest X-ray. By doing CT scan of the chest, you may detect micrometastasis in 40% of the patient with a normal chest X-ray. But usually this will not change the outcome. Other imaging study like CT scan of the abdomen and pelvis, MRI, or CT scan of the brain, this usually should be considered in a selected patient. Like if there is evidence of lung or vaginal metastasis, if a patient has a symptoms like neurological symptoms or laboratory like elevated liver function test that suggest of metastasis, or if there is a histological evidence of choriocarcinoma, because we know choriocarcinoma is a highly metastatic, so you better to do CT scan of the abdomen and pelvis and MRI of brain. So the staging of the gestational trophoblastic neoplasm, stage 1 means confined to the uterus, stage 2 extend outside of the uterus, but usually limited to the genital structure, stage 3 if there is lung metastasis, stage 4 if there is other metastatic disease. The WHO prognostic scoring system depends on 8 risk factors, including age, antecedent pregnancy, interval, which is the time between the end of pregnancy and the start of the chemotherapy, pre-treatment serum beta HCG, largest tumor, site of the metastasis, number of the metastasis, and prior failed chemotherapy. So if the scoring is 0 to 6, this means low risk. If the scoring 7 and high, this means a high risk. Usually we need the WHO prognostic score mainly for stage 2 and stage 3, because stage 1 usually low risk, while stage 4 usually high risk. And we don't use it, the WHO prognostic score, for placental site trophoblastic tumor or epithelial trophoblastic tumor. So differential diagnosis for high level of beta HCG, it could be normal pregnancy, abortion, or ectopic pregnancy. The other is ectopic beta HCG producing ovarian tumor in general, like ovarian germ cell tumor, cancer of the stomach, liver, breast, and pancreas. The other differential diagnosis could be pituitary beta HCG, and this is occur at the time of the menopause, which could be either natural or post-surgical. And this is usually because of the luteinizing hormone level peak, usually produce at the same time small amount of the beta HCG, and the level usually between 20 to 40. How can you confirm that the high level of the beta HCG because of the pituitary? Usually by using oral contraceptive for 3 weeks. If there is a suppression of the beta HCG, this means that it is clear the source is pituitary beta HCG. The other cause is false positive beta HCG, which is called phantom beta HCG, and this is mainly due to circulating heterophilic antibodies. This is a large molecule that mimic the beta HCG when they detect in the serum. How can you diagnose? Usually you will not detect the beta HCG in the urine, and variable beta HCG result when it done in a different labs. So I will talk first about low risk GTN. So the low risk GTN include stage 1 GTN, stage 2 or 3 with the WHO prognostic score less than 7. Low risk GTN can be cured with a single agent chemotherapy, which is, when you talk about solid tumor, this is the only disease that you can cure only with a single agent chemotherapy. Overall, excellent prognosis with a cure rate approaching 100%. But sometimes you may require for your patient subsequent treatment to achieve cure in around 20% of the patient. So initial therapy, usually we use single agent methotrexate. Sometimes you may consider hysterectomy for a patient if she doesn't desire fertility, and by doing hysterectomy you may reduce the number of the exposure to the chemotherapy after the surgery. But most of the case we advise after hysterectomy you may give one course of the chemotherapy to treat micrometastatic disease. Salvage therapy, which includes single agent deactinomycin. If a patient failed 2 single agent chemotherapy, then we may consider multi-agent chemotherapy like EMA-CO, and you may consider hysterectomy in a selected patient with a chemo-resistant disease if it is a stage 1 disease. So there's a 4 different chemotherapy regimen. And why we have a 4 different? Because of lack of high quality data. There is no randomized trial to comparing each regimen with, in between. So, can be used weekly methotrexate, can be used 8-day regimen of methotrexate, can be used 5-day regimen of the methotrexate, or can be used high dose methotrexate. But the most methotrexate either weekly, 8-day regimen, and sometimes 5-day regimen. Deactinomycin, it could be either bi-weekly pulsed regimen like 1.25 every 2 weeks, or it could be 5-day regimen for 5 days every 2 weeks. So this is 2016 meta-analysis in which patient with a low risk GTN treated with a single agent chemotherapy, so comparing single agent deactinomycin versus single agent methotrexate. And this include 7 randomized trial comparing both, and you can see with the actinomycin, there is a high cure rate as compared to the single agent methotrexate, with the relative risk ratio is a 0.65, which is significant. From our experience at KFSH, 131 patients with a low risk gestational trophoblastic neoplasm treated with a chemotherapy, and you can see the complete remission to the initial chemotherapy was around 70%. When you look for a single agent methotrexate was around 53%, single agent deactinomycin was 87%. Around 25% of the patient require a salvage therapy, and overall complete remission, either to the initial chemotherapy or subsequent chemotherapy, was around 90%. So, in general, we prefer to give single agent methotrexate because of lower toxicity, decreased cost, and advantage of convenience. And we may keep the single agent deactinomycin as a salvage therapy for a patient who has methotrexate resistant, or as a primary therapy when there is a contraindication to the methotrexate like effusion, renal, or hepatic impairment. During therapy, beta-HCG should be measured weekly after a complete remission, which means that beta-HCG should be below 5, then we can continue for additional 3 cycles. Sometimes you may consider observation for a patient with a raised beta-HCG 6 months after molar evacuation if it's still falling down. And they found by the study that if you follow only by observation, around 80% of the patient, they may get spontaneous remission. And only maybe 20% of the patient that you may need treatment. So if a patient willing to continue follow-up like every 2 weeks with the beta-HCG, and the beta-HCG is going down, even after 6 months, you may consider only observation. High-risk GTN, it includes stage 4 disease, or stage 2 and 3 with a risk score more than 6. Usually treated with a combination chemotherapy, and the preferred regimen is EMA-CO. Overall cure rate for the high-risk stage 2 and 3 range between 95 to 100%. For stage 4, the complete remission is achieved 60 to 70%. Still, about 30 to 40% of the high-risk GTN patient will develop resistant or relapse and require subsequent combination chemotherapy or surgery. So the EMA-CO regimen, usually day 1 will be etoposide deactinomycin methotrexate, day 2 etoposide deactinomycin, and day 8 will be cyclophosphamide and vincristine, and usually this regimen will be repeated like every 2 weeks, every 2 to 3 weeks. So this is a retrospective study from the Korean Center, 227 patients with a high-risk GTN treated with either methotrexate deactinomycin or methotrexate deactinomycin and chlorambucil, or Chamuka, which is a combination chemotherapy, or EMA-CO, and they found that the highest remission rate with the EMA-CO, 91% as compared to the other chemotherapy, which is ranging between 63, 68 or 76% respectively. Lowest mortality rate with the EMA-CO, 9% as compared to the other combination chemotherapy. So usually prefer to use EMA-CO. From our experience, at KFSH, 88 patients with a high-risk GTN treated with the combination chemotherapy, and you can see the complete remission rate to the initial chemotherapy was 57%, and with the EMA-CO, the complete remission rate was 94%. While the other chemotherapy, this is used, like in 70, earlier, before we, use EMA-CO, and you can see the complete remission to the chemotherapy was better with the EMA-CO. 34% of the patient require a salvage chemotherapy, and overall complete remission to either initial chemotherapy and the subsequent chemotherapy, or may include the surgery, was 73%. So usually beta-HCG should be measured weekly during the therapy for the high-risk GTN. After complete remission, when the beta-HCG become below 5, usually we will continue for additional 3 cycles, which means like around 6 weeks. In selected patients with a high tumor burden, initially, in order to reduce the early death due to hemorrhage or respiratory compromise, especially if the patient has a bulky lung metastasis, usually we start with the low-dose induction chemotherapy. So we use etoposide 100 mg per meter square and cisplatin 20 mg per meter square on a day 1 and 2, repeated weekly for 1 to 3 weeks. So you decrease the load, the load of the disease, the burden of the disease, and then after that you may continue on EMA-CO. So the risk of the hemorrhage will be less. So initial therapy, usually we use EMA-CO chemotherapy, but sometimes if a patient has brain metastasis, we use EMA-CO with a high-dose methotrexate, 1000 mg per meter square over 24 hours. Better to get a neurosurgical consult prior to the treatment because of the high risk of the complication, either with a brain metastasis or as a consequence of the treatment, and mainly is intracerebral bleeding. So better to get a neurosurgical consult before that. Some center, they may use whole brain radiation in addition to the EMA-CO, the high dose, and their rationale that by using the whole brain radiation, you may shrink the brain metastasis, you may increase the concentration of the methotrexate in the CSF, and you may reduce the risk of the intracerebral bleeding, but usually this associated with the increase the treatment-related toxicity of methotrexate like leukoencephalopathy. Sulfate therapy for a patient who failed EMA-CO, usually we consider EMA-AB, and this means that at day 8, we use etoposide cisplatin instead of cyclophosphamide vincristine. The other regimen that can be used as a third line or is Taxol etoposide alternating with the Taxol cisplatin, BVB, which is cisplatin, vinblastine, bleomycin, or paclitaxel carboplatin. You may consider surgical resection like pulmonary, hepatic, if you have a solitary lesion with the chemo-resistant. So, the definition of the resistant disease, if patient on treatment and there is increase or plateau in 2 consecutive beta-HCG value over 2 weeks interval, this means a resistant, or if there is a detection of the new metastasis. Recurrent disease means that beta-HCG re-elevate after becoming undetectable for 3 consecutive weeks. We know that the half-life of the beta-HCG is 1.5 to 3 days, so usually it should be, the level should be full by 1 log over the 18 days. So if become plateau or increase, this means that resistant and you should switch treatment. When a patient get a resistant or recurrent disease, better to do restaging again. So you consider CT scan of the chest, abdomen, pelvis, and MRI of the brain to decide what treatment. You may consider combination chemotherapy. If there is a solitary lesion, you may consider surgical resection. Sometimes we may consider PET scan to distinguish active disease from fibrotic tumor nodules when there is a plan to do surgery like pulmonary metastectomy, so you want to be sure that this is active disease or fibrotic nodule. Post-treatment surveillance after complete remission is achieved. Usually we do beta-HCG level should be measured monthly for 12 months, then every 3 to 4 months for the second year, then every 6 months for the third year. And 85 to 95% of the recurrence occur within the first 18 months. And usually the risk of the recurrence like 5 to 10% if achieve complete remission. Women should use contraception during the therapy and surveillance to be sure that the there is no pregnancy in the future, so this will make you, if beta-HCG elevated with a pregnancy, is it because of the pregnancy or still there is active GTN? So we advise that patient should be in contraception. Patient may attempt to achieve pregnancy after 12 months for low-risk gestational trophoblastic neoplasm and 24 months for the high-risk gestational trophoblastic neoplasm. What is the definition of the Quiescent GTN? Definition, it means plateau of beta-HCG at a low level, usually below 200 for at least 3 months. And usually there is no evidence of primary disease and there is no evidence of metastatic disease. Typically occur after molar pregnancy or GTN. So patient after molar pregnancy, the beta-HCG may fall down until become below 200 and then become plateau. And this is more likely if there is no evidence of primary or metastatic disease that's quiescent. Usually characterized by little or no hyperglycosated beta-HCG will be seen on SA due to few cytoplastic cell. Generally chemo-resistant. So usually only what we need is a follow-up because 20% can develop GTN, and this is usually you will find with a follow-up 2 doubling of the beta-HCG, and beta-HCG become hyperglycosated in more than 20%. So patient, if we consider this patient has a quiescent GTN, usually we follow the beta-HCG like every month. What about placental site trophoblastic neoplasm and epithelioid trophoblastic neoplasm? Usually characterized by growing more slowly, metastasizing later, involve lymph nodes more commonly, and produce low level of the beta-HCG. Most commonly occur after non-molar abortion and pregnancy, but can occur after molar pregnancy. Diagnosed several months or years after pregnancy, usually relatively resistant to chemotherapy, so what we use usually is a combination chemotherapy. Modified WHO prognostic scoring system is not useful for placental site or epithelioid trophoblastic neoplasm. Stage 1 usually treated with a hysterectomy. We may consider adjuvant combination chemotherapy if disease presenting for more than 4 years of antecedent pregnancy. Stage 2 or 3, combination of surgery and chemotherapy. Metastatic disease usually associated with a poor outcome, and we treat with a multi-agent chemotherapy, which could be either EMA-CO or EMA-EB. So I will give you, still there is a time, so I'll give you an example for a case presentation. So this is a 30-year-old female, BRCA1 plus 0, not known to have any medical illness. She had a full-term pregnancy with a spontaneous vaginal delivery at 27 June 2014. After that, she had a continuous vaginal bleeding and underwent dilatation and curettage at 22 September 2014, which showed choriocarcinoma. She required blood transfusion twice because of low hemoglobin and continuous vaginal bleeding. She presented at our hospital at 13 October 2014, complaining of mild beefy bleeding on and off with history of mild headache. There was no history of nausea, vomiting, abdominal pain, shortness of breath, cough, or blurred vision. While she was inpatient, she developed one episode of seizure and she was treated with the Kebra. On a physical examination, was unremarkable except that she is pale. Her hemoglobin was 96. Otherwise, renal hepatic function was normal. Beta HCG was more than 1 million, and she has a picture of hyperthyroidism. T4 was 71.6, which is high, and TSH less than 0.05. So this is the chest X-ray, and you can see there's like multiple bilateral well-defined nodules in both lungs, and when you account, it is more than 8 minimum. And this is the CT scan, and you can see there is a bilateral multiple pulmonary metastasis. There is a uterine mass, which is around 7 by 4.7 centimeter. There is a bilateral complex ovarian cyst, and it is ovarian thecal lutein cyst, and there is hypodense lesion at the segment 7 of the liver. This is the MRI of the brain, which shows enhancing lesion in the left parietal temporal lobe and also at the right cerebellar hemisphere. So what stage she has? Stage 4. What is the WHO prognostic score, if you want to account? Yes, so it is a stage 4, usually stage 4 high risk. Usually we don't account for a WHO prognostic score, but if you account for this patient, it will be more than 16. So the first, 16. So the first 30 years, so it is less than 40, 0, but she has a full-term pregnancy, which is a 4. She was diagnosed within a 4 month, so it is 0. When you talk about beta HCG, it is more than 100 million, which is a 4. There is a lung metastasis 0. Lung metastasis, but if you account, it is more than 8. So it is like another 4. And also there is a brain metastasis. And the tumor size is 7 by 4.7, which is like around 2. So when you account all this, it will be 16. So usually stage 4 in general is a high risk. So how can you manage this patient? So EMA-CO with the high-dose methotrexate. So she received 13 cycle, completed on 13 March 2015. And you can see when you look to the beta HCG, is going down, then at 60 become plateau. So when a patient reach 60 become plateau, this means that maybe resistant disease. So usually we'll do restaging to show where is the disease now. So by restaging, still there is a bilateral lung metastasis. There is a significant response, like more than 70%, but still there is a bilateral lung metastasis, and the largest was 1.5 centimeter. Now normal uterus, normal ovary, but there is a new hypodense lesion in the liver, in segment 7 and segment liver, and segment 8. So there is a new liver metastasis, and still the beta HCG plateau. So the brain CT scan, the MRI brain showed interval resolution of the enhancing lesion in the left parietal lobe and cerebellar lesion. So it is resolved. So now you have a resistant disease with a plateau beta HCG with a new liver metastasis. So how can you manage this patient? Asymptomatic. Sharifa? But why hysterectomy? Normal uterus. And the disease outside the uterus. So because there is a new liver metastasis, still there is a lung metastasis, and beta HCG became plateau at 60. So she was treated with the second line combination chemotherapy. There is no brain metastasis, no. So we give her EMA-EB, 7 cycle, completed at 23 August 2015. And you can see the beta HCG dropping down until become below 5 and then achieved complete remission. So she finished in August 2015. This repeating CT scan at January 2017, you can see more significant response, and the only lesion remaining, it is less than 1 centimeter, 6.3 millimeter, which is more likely to be fibrotic nodule, and resolution of the liver metastasis. And this lesion since long time is still, and most likely hemangioma, but the new lesion was in segment 8 and 7 is resolved. So this is in January 2017. And on a follow-up, repeating beta HCG in January 2018, which is around 2.5 years after the last, second line of chemotherapy, still beta HCG normal. Okay, thank you. Thank you.